All right, good afternoon, everyone. Thank you so much for joining us for today's webinar, Rethinking Mental Health Care for Chronic Pain. Before we begin, I'd like to offer a land acknowledgement. The standard land acknowledgement is on the screen, but I also wanted to share a personal one as a way of introducing myself. So my name is Ari, and I'm one of the education leads at Pain Canada. I don't live with pain personally, but I have loved ones who do. I grew up on the stolen territories of the Sioux Okanagan Nation in what is now known as Vernon, BC, and I've been learning and working on the territories of the Musqueam, Squamish, and Tsleil-Waututh First Nation for the past 13 years. It's an honor to be with all of you here today, and I thank you for taking the time to join us for this important conversation. I'd briefly like to thank our sponsors. So this program has been made possible through financial support from the CIHR Institute of Musculoskeletal Health and Arthritis, as well as the Partnership for the Engagement of Patients in Pain Research, or PEPR. We hope that you will ask lots of questions and participate in today's webinar. To ask one of our presenters a question, please use the Q&A feature, which is in the Zoom toolbar at the bottom of your screen. Note that we will not read your name out when asking your question. If you have a technical question or have a question for me, please type it in the chat. So we have a CART live transcription for today's webinar. So if you would like to view that, you can select the link, which I've pasted in the chat, and I'll paste it again, and that you'll be able to, that will open in your internet browser and you'll be able to see the live transcription. So thank you so much to Canadian Hearing Services for providing that today. The recording for today's webinar will be posted on Pain Canada's YouTube channel, which is youtube.com/@PainCanada in the next couple of weeks. If you have any questions or need help, please don't hesitate to contact us at education@painbc.ca. As usual, we've got a packed agenda today, so in a moment I will hand things over to Alex, who give us a kind of brief overview and context for today's discussion. Then we'll have presentations from Don Gibson, Dr. Jennifer Stinson, Desmond Williams, and then we'll end with about 15 minutes for an audience Q&A, which Alex will moderate. Okay, without further ado, I will turn things over to Alex. Thanks so much, everyone.
Thanks so much, Ari. My name is Alex Hagar. My pronouns are they, them. I will be moderating today's discussion, and I'm joining from so-called Kingston, Ontario, which is the unceded territory of the Haudenosaunee, Huron-Wendat, and Mississauga peoples. I'm going to give a little bit of background on why we've organized this particular webinar, what the topic means to me personally, and what we're hoping that people will get from it. Just as a heads up, I will be briefly discussing some experiences of medical abuse and neglect over the next 5 minutes. So if that brings up distressing memories for you, please feel free to mute this or step away for a few minutes, do whatever you need to in order to take care of yourselves. So I work as a design researcher focusing on accessibility and disability inclusion in user experience, so digital websites and apps, and service design. Right now, I work at a digital mental health platform, and that has been shaping what I've been thinking about lately in my own healthcare advocacy as a person with lived experience, or PWLE. I've got lived experience of a lot of things that relate very closely to the work that I do in design for digital health. I've got lived experience of chronic illness and chronic pain, lived experience of struggling to access diagnosis and care, lived experience of mental illness stemming in part from medical trauma, and lived experience of being incredibly wary of seeking help for that mental illness because of my lived experience of having my physical illness labeled as psychosomatic and therefore dismissed. There was the time that I showed up at the emergency room in my hometown with a GI bleed that was so painful I was screaming, because screaming gave me something to focus on so that I wouldn't pass out. And there was something instinctively telling me that if I passed out, it would be very bad. After 2.5 hours lying on a gurney, the on-call doctor came in and told me off for bothering everyone else with my noise. A few years later, when I took a look at my patient record, I discovered that he had written down that that night I had somatization disorder due to neurotic anxiety. Um, there was a time in university that my platelet counts dropped to about 45 for a period of a couple months, and they couldn't ever find an explanation for it. So my hematologist explained to me that it was probably stress. There was a time that my first sleep specialist attributed my, at the time, undiagnosed narcolepsy to depression and told me that the reason the first line meds hadn't been working at all was that I wasn't trying hard enough to control my sleep cycle. Earlier this year, I was filling out intake forms for a local pain clinic, and I made sure to answer no to the questions that asked about history of mental illness and childhood sexual abuse. I was angry for days after filling out that form. I'm still angry about it. I'm angry that I had to lie about my own trauma in order to protect my access to the medical care that I actually needed. And I'm angry on behalf of all the other people who I know may not have learned yet that you do need to lie about these things in order to access physical care. I was also afraid for the weeks between filling out that form and actually having my intake appointment that I would be pushed into psychotherapeutic approaches that I have found to be harmful in the past, and that counseling would be, another hoop I would have to jump through to access the nerve blocks I was actually asking for, and that I would have to pretend to try pain acceptance when I'm actually in the process of doing exactly the opposite. Because for the first few decades of my life, I learned to accept my pain so well because I was told over and over again that I wasn't in pain, that I was just imagining it, that I was just attention seeking, that it was normal, it's growing pains, you just need to exercise more, you're just depressed, you just need to stop thinking about your body so much. That eventually I did, and I stopped being able to feel pain. And now I can self-propel in a wheelchair for a week without realizing that my wrist is broken, which frankly is a bit of a problem. So I'm in the process of unlearning how to accept my pain. And for me personally, and I know for a lot of other people, pain acceptance strategies can be very, very harmful, and yet they're expected as something we need to try. And if we don't, we're seen as being non-compliant. At the same time, I believe that people in chronic pain do urgently need access to mental health supports. Chronic pain and illness are traumatizing in and of themselves. To put it bluntly, it is incredibly messed up to be unable to rely on your own body and to sometimes be quite literally tortured by it. And, at the very least, to be unable to participate fully in life the way that you want to. There's the medical abuse and neglect that unfortunately many of us have experienced that is traumatizing. The poverty that we're disproportionately subject to when we can't work, or when our work deems our access needs unreasonable, or when we're forced into the poverty cycle through disability income, or when we're denied access to disability income because we don't look disabled enough to our doctors. That is all traumatizing. There's the loneliness that we experience when we're largely abandoned by our non-disabled friends and family who don't understand our support needs because they can't see anything physically wrong with us, who tell us we just need to exercise more or think positive or cut out sugar or eat more kale, who have decided that the pandemic is over and then wonder why we never come out and socialize anymore. All of that is traumatic. And at the same time, it's very difficult to find mental health care supports for people who are living with chronic pain that don't either try to get us to do pain acceptance or reiterate those same tired pieces of advice that we've heard over and over from our non-disabled family and friends. And that is why I wanted to bring together 3 people who are working to build the kinds of supports that we actually need. These folks are doing work that is either grounded in their own experiences of chronic pain and illness, or that's produced through co-design with people with lived experience. And their methods go beyond the usual sort of cognitive behavioral therapy, acceptance commitment therapy, generic healthy lifestyle approaches that we're so often bombarded with, and they instead focus on somatic approaches, community building and peer support, education about and connection to material, as well as therapeutic resources. And my hope is that the people with lived experience who attend this webinar will get some encouragement from having your experiences validated. I know that for many years, especially the early years of my journey, it meant so much just to know that I wasn't the only one experiencing these things, but also to learn about some mental health supports that do exist, that are out there, but maybe hard to find, that may be useful to you. For the clinicians, researchers, and policymakers here, I hope that you learn about the complex needs, challenges, and risks that we face when dealing with mental health struggles as people with chronic pain, and hopefully maybe identify some opportunities where you can connect your own patients to new resources, integrate new approaches into your own practice, or advocate for changes to how we approach pain and mental health care on a systemic level here in Canada. And so with that, I will pass the mic over to Dawn Gibson, who's our first speaker.
Hello, I'm Dawn Gibson. I know that some of you might know me from my work on Twitter or some other places. Basically, I'm a former Anglican young adult lay chaplain turned writer and social media health advocate and family caregiver for dementia and skin cancer. I help found the National Pain Advocacy Center in Colorado, where I now serve as a secretary and I lead the community council. In 2002, I was diagnosed with spondyloarthritis after about a year of symptoms. Basically, spondyloarthritis is a kind of trickster nightmare illness that has lots of inflammation, lots of fatigue, pain, reduced range of motion, and can attack any part of your body at any time and bring life to a screeching halt. When I was diagnosed, I wasn't told how serious the illness was, like, in terms of life impact or anything like that. So I was just kind of pushed out into the world, into the desert wilderness on my own without any help or support, trying to figure out how to make my life work. By 2011, I was on Twitter and I had joined the kind of combo rheumatology, gluten-free, and food allergy squad. And from that, very fertile ground for just thinking about access and thinking about how to make our lives work, how to stand up for ourselves, all of that kind of thing. I founded Spoony Chat, which is a weekly Twitter event that is for anybody who has an invisible disability or illness. We also have some caregivers who join and some researchers from time to time. And my main goal was to bring patients together around solidarity, helping people get good information, things that truly empower about how to take care of ourselves, how to have a good medical appointment, how to stay current with the information on on whatever diagnosis we're living with. And I had the idea that this influx of information and support would improve outcomes for patients. I have no proof of what outcomes we have achieved in our 10 years together, although I do hear from patients that being in community helps them feel stronger and helps them participate in their lives in a way that is what they need. So I feel strongly convicted that yes, we are accomplishing something. How much and how durable, I don't know, and I cannot prove it. But what our community that we've grown has really expanded to encompass almost any diagnosis of any kind. And I'm proud to say that we've been bringing more and more people with mental illness and other behavioral and mental health concerns into the fold, and it's going great. Our membership face a wide variety of barriers to access to healthcare, but particularly access to mental health care. And a lot of it has to do with the fundamental threat that chronic illness has to the ability to live independently and to exercise our personal autonomy. And without this personal autonomy, people aren't getting anywhere. They just aren't, or they're not getting there consistently. There's always something that jumps up and bites them and interferes with what they're trying to accomplish. Some of the main threats that they experience are inconsistent energy and inconsistent ability to function. This might be described as episodic disability. They have high rates of fatigue and pain. Many of them are unable to work or unable to work consistently. And if you can't work consistently, you may as well not be able to work, because nobody wants to hire you if you cannot work consistently. Our community also deals with intergenerational trauma with many causes, including racism, anti-Semitism, poverty, and other marginalizations, family legacies of incarceration and immigration difficulties, low access to transportation and quality internet, low access to good food, insecure housing or being unhoused, and medical trauma. I think those are the most pressing and evident concerns that I'm able to detect on the timeline and in my decade of being in communion with the community. But there are many things that nobody has told me, and they keep those things private. it's important to center trauma in our conversations about accessing healthcare, but particularly about mental health care. And I believe that we should be centering a trauma-informed care approach. And one of the most important things is just to avoid re-traumatizing anybody. Like if you can't make it better, don't make it worse. Just please do not make it worse, because when we make it worse, it has a compounding effect, a force multiplier of just disrupting the good things that have happened and escalating the bad things that either have happened or can happen. So it's just important to me that if you're going to be interacting with chronic pain patients, you don't make it worse. And understand that every chronic pain patient is vulnerable. And some of the vulnerabilities we have are feeling helpless, feeling hopeless, feeling forgotten and discarded, feeling too damaged to matter to anyone, feeling exposed, or being suspect of perpetrating some type of fraud, suspect of being drug seeking, suspect of being manipulated, all of these things. And we carry these things with us, but they're also triggered often by our interactions with the system or by just terrible comments and things, just petty, terrible things that people like to do to each other, whether that's in the healthcare system or without. So as we contemplate the barriers to mental health care for chronic pain patients, it's important to consider the use disorder stigma. And I feel strongly that pain patients should never throw anybody with a use disorder under the bus to make their point. It is not right. Everybody is a patient. Everybody needs care and all of that. But it's also true that this fixation on ferreting out as many use disorder patients as possible is harming every chronic pain patient and their ability to participate in their own care. There's also concern about laziness, and this is particularly true with episodic illnesses. For myself, I can have some really good days, and you might see me working in my garden, you might see me running errands, I might look like any normal person, and then day 3, all the magic is gone, and I wake up feeling like something the cat dragged in. Someone could look at that and say, well, there's nothing wrong with her. She works when she feels like working, and she doesn't work when she doesn't want to work, or she decides when she's sick. I don't decide any of this, I promise. I wish I could. There is also a widespread lack of awareness of the complexity of disabilities or pain-associated disabilities. So outsiders don't tend to get it. And there's the other problem is that pain is like fatigue. It's easy to confuse a normal type of pain where maybe we just overdo it and we'll get better after a couple of days, or taking an NSAID or something like that. And there's the issue of fatigue and tired. Everybody has been tired, not everybody has been fatigued, but these things get conflated, and it's difficult. Overall, I find that there's a lack of trust in the system. So patients can't trust their clinicians can't necessarily trust their patients, or they don't feel empowered to trust them because of the way the system is organized. The other issue that we're having is and as a very painful issue of vicarious traumatization. And this is one of the confounding difficulties of living in the social media era, where when something bad happens to a patient, that news spreads. And there's an opportunity in that, because ultimately we can hold some people accountable, but the problem is that also raises fear in accessing the system and the ability to trust the system. So I urge people to use caution consuming that type of material, because it's not helpful if it stops you seeking the healthcare you need. It just isn't good. And there may be better ways to address that issue through reforms, through advocacy organizations, rather than consuming that content. So just kind of go mindfully with that kind of content. I believe that community-based approaches could advance the agenda of better access to mental health care for chronic pain patients, but it's only, it's a part of things. I'll put it that way. It's not our total solution, because some people do need professional mental health care that their peers cannot support. Overall, I think that our health social communities do a good job of socializing the idea of having good self-care, particularly boundaries, and having a self-care plan, because we all talk about that. You know, how much that has done for us. That's the first place I even heard of boundaries or self-care was on Twitter. And a lot of people, nobody told them growing up. So something to think about, the power of people modeling the way that their lives have been transformed for others to see. The other thing is that we all need recognition and a sense of belonging, and that's a place that's a need that our communities can fulfill. Ultimately, no matter what specific items we're trying to have people participate in, everybody needs something to look forward to in their lives, and something that is not medical, something that is not politics, that is not some like gigantic cause or burden that we're carrying, but something that gives us hope. Because when we have that hope within us, then we can advocate for ourselves. We don't feel like there's any a point to keep going. We say, well, I really want to do that thing. I really want to become this person in my community or whatever. For me, I like to raise butterflies, and I like to decorate the world's most elaborate and ridiculous looking Christmas trees. Like, I've got a giant octopus on my Christmas tree, and it makes me so happy. Her name is Charmian. She is the Merry Christmas, Omnibus, Happy Holidays octopus. She celebrates everything and everyone, and she looks like a real octopus that could come to life. That is bananas, but I love it. And nobody is going to take Charmian from me or make me give up on Charmian. I just love her. So it doesn't matter what it is, but you must have a cause that is joyful and beautiful for yourself, no matter what. And if you have that thing, you may be able to keep going when it feels too difficult to keep going, when it feels too difficult to seek that healthcare, to trust that system, all of that. I think my last 2 points are going to be about where people are going, and just a few proposals. I'm noticing a lot of energy in the coaching space, and this mental health coaching could be for just general mental health and learning boundaries and all of that. But I'm also seeing a lot of people working on trauma, recovering from narcissistic abuse, managing ADHD, complex post-traumatic stress disorder, all of this stuff. This cuts both ways, because some of these people have no idea what they're doing. And I get very nervous when I see what they're saying and telling people to do. On the other hand, the fact that people are going there shows that these coaches are making a connection. They have found some success. And I think we need to look at what is causing people to trust the coaches, what the coaches are doing well, and what might be improved. I do get really nervous sometimes, though, because I'm concerned that people aren't necessarily getting care that is matching their specific concern, or they need more that a coach could provide, such as medication or something else. The last solutions I'd like to propose are increased access to therapy and interventions by telehealth, because a lot of pain patients have a hard time leaving the house, and it's a big ask for people to leave the house, let's say every week, just for one thing. That's going to be a lot for some people to take a shower and get dressed and use that energy, and maybe they might need to go grocery shopping or walk their dog or whatever. There's going to be an offset, an energy offset, a big expense. I would like to see improved peer support, maybe with some more research behind it, to boost the efficacy of what's being suggested. And the other thing is, I would like to see access to anything that is going to disrupt these intergenerational trauma events, because we talk all the time about how children are resilient. They are absorbent. They are not resilient. And so when children are traumatized, that's just restarting this cycle, and it needs to stop. In conclusion, I would like to draw everyone's attention to the work of Aon Gilmer. Aon Gilmer was a tenacious disability and health campaigner. She unfortunately passed away in 2021 by suicide. Her work on trauma-informed care and health privacy is amazing. And if you go to her Twitter, which is a memorial page now called @Gilmer Health Law, you can see all her amazing tweets, and you can click through from her profile onto the onto her website and see what she has to say about how the system let her down and lets a lot of patients down, and what could have gone better. You know, we lost Erin before she even turned 40, which is outrageous. I think that Erin is a symbol of the beautiful potential in our community and the deficits in our system and what we need to do better. So if the only thing you remember out of this presentation is my friend's name, Aon Gilmer, that's good.
Thank you so much, Dawn, and thank you for memorializing Erin that way. I'll pass to our next speaker, Dr. Jennifer Stinson.
Okay, thanks everyone. I just want to thank Dawn and Alex and Desmond, who will go after me, for sharing their experiences and contextualizing the problem. And then I'm going to talk more from the healthcare provider and researcher perspective of some solutions that we've developed to help overcome this. And so I'll talk about the development and implementation of the Power Over Pain portal for youth with chronic pain. So I'm a nurse by background. I work in the chronic pain clinic at Sick Kids, and I'm very passionate about developing digital health solutions and peer support for young people with chronic pain. So we all know the impact of chronic pain on mental health, but the pandemic actually represented one of the biggest threats to youth mental health that we've seen in generations. The stress of the pandemic actually resulted in people developing chronic pain and then exacerbating the pain that they already felt. And we know that it's similar to adults, that 1 in 5 young people will experience chronic pain in their lifetime. So what we did during the pandemic, the Canadian Institutes for Health Research provided a lot of money for COVID-related research. And myself, Katie Birdie, and Melanie Knoll from the University of Calgary wanted to look at what the impact of the pandemic was. So we used a phased approach. And in the first phase, in Canada, there are 13 clinics or dedicated outpatient programs that see youth with chronic pain. So we wanted to survey those medical directors, and we also did a survey across healthcare providers across Canada. And we found that almost all of the pediatric chronic pain programs had to stop care for months, and some even longer than that. Some of the clinics were able to pivot to virtual care quite quickly. At Sick Kids, within 72 hours, we were able to pivot to virtual care, but we have a lot of virtual care infrastructure at Sick Kids, and a lot of places didn't. People talked about, and you heard from Dawn, all of the sort of barriers for patients, but there are barriers for clinicians as well in terms of providing virtual care, in terms of not having the technology, the infrastructure, privacy concerns, et cetera. Then what we wanted to do, we interviewed qualitatively some of the respondents to that survey that I just talked about, in terms of like child life specialists, nurses, physicians, physical therapists. And they talked about the duality of the pandemic for young people. So for some young people who actually didn't like going to school or going outside, the pandemic actually made their pain better. But there's a group of people that really thrive on interactions with other people and going to school, and that's a mechanism for coping with their pain. And so that exacerbated their pain. And there were definitely inequalities due to socioeconomic inequalities that Dawn has already addressed. And then all of a sudden, all of our wait lists for these clinics became tripled. So it was a challenge to get people in for these services. And again, as I mentioned, there were some challenges of pivoting to virtual care, but most people talked about, now that we've gone to virtual care, that we need to continue with these hybrid models of care, because for some patients and families, that means that they really can access this without having to travel or the additional costs associated with coming into a big urban center. Oh, sorry, go to the next slide. We then did a survey of over 350 young people, parents, and siblings about the impact of the pandemic. And almost 60% of them said that their pain was worse during the pandemic, that they had increased in moderate to severe anxiety. 50% of those that we surveyed had possible major depression. And similar trend to even healthy kids, there was increase in drug and alcohol use during that past 12 months. And what was concerning is that more young people were seeking care for chronic pain in the emergency departments or primary care, which we know is already overburdened. We also did qualitative interviews with the young people and their family. And again, they talked about how they lost some of their coping mechanisms during the pandemic and their shifting roles, not being able to see their friends, feeling abandoned by the healthcare system in terms of not being able to get care in the community, in terms of psychologists or physical therapists, et cetera. But they did talk about some strengths. And one of the things that came really clear was this notion of family cohesion, of how these young people actually increased their bonds with their family and felt at times better, more confident and better to manage their chronic pain condition. So Katie Burney led a review of virtual care best practices, and it's kind of shocking actually that we actually don't have guidelines on best care practices for delivering virtual care, especially around families, that it should be freely available. It needs to include training of not only healthcare professionals, but some training for families. It should be developmentally appropriate, transparent communication, and that really young people should decide if they want to do virtual care or come into the hospital for face-to-face care. We also looked at what evidence there is out there for self-management, and things like Dawn talked about the importance of peer support. But you can see the size of the bubbles represents the like critically low evidence that we have. And you can see that for most of these things, in terms of psychological strategies, symptom tracking, social support, we don't have a lot of evidence, at least in young people, for some of these strategies. So I'm not sure if people are familiar, but Stepcare is an approach that's been used in mental health, and it's really been strongly encouraged by the Mental Health Commission of Canada, is to provide people with care that's tailored to their needs. So the first is sort of self-guided, then there's peer support, then there's minimal healthcare professional involvement, and then real time, and then coming to the clinics for those people that really need it. And that people should be able to move up or down this continuum as their needs change. And so people, during the pandemic, the Canadian government, which was great, developed what's called Wellness Together Canada. So this was curated resources for mental health, and that each province had resources so people could access care along that continuum. And so we wanted to develop something similar for young people with chronic pain. And Alex talked about the notion of co-design. So in my lab, I don't do anything without young people involved as key players in the development. So we put out a call across Canada, and we had 54 young people apply to be part of our youth advisory to help develop and co-design the Power Over Pain portal. And these are just some of the pictures of our advisory group. So we developed the portal, and now we had funding from CIHR to do two studies. One is in primary care. So most of the people that have chronic pain are seen by their family doctors and don't actually probably need to see a tertiary care clinic. And so we are trying to recruit 100 participants, and we're a third of the way through that study. And then what we're also trying to do is show that this intervention can help people. Now that our wait lists are 6 months and longer, we're trying to offer this intervention while people are waiting to see a tertiary care clinic. And our hope is that we might be able to actually get some of these people off the wait list and improve their pain management by using this portal early on. This is what the portal looks like, though the portal is freely available. It's available in English and French. This is the youth portal, but there's also a portal for adults. This is what it involves. So there is a registration, and people don't have to register, but if they register, then we will have data on who's using this in each province to go to Health Canada to see if we can get money to sustain this. It has a tracking feature, so people can track their progress over time. And based on their tracking, the young people said that they don't want to scan through all of this. They want the portal to be able to provide them tailored advice, and that's what it does. The portal also has peer support and peer navigation component as well. These are just some of the examples of resources. So we have examples for pain, we have examples for mood and worry, for sleep, and for substance use as well. So just to wrap up my piece of this presentation, I think access to virtual care solutions is essential. Dawn alluded to it, Alex alluded to it, I'm sure Desmond will as well. But really that Stepcare approach where people can tailor what they need at the right time to help with their pain, I think is crucial. And I just want to thank, this is a team of people from across Canada and young people living with pain, and just thank all the collaborators.
Thank you so much, Dr. Stinson. That was great. I will pass it to Desmond now.
Yitik Shadish, Desmond Williams and Shquesh. Good afternoon. My name is Desmond Williams, and thank you for joining me. Thank you, Don, Dr. Stinson, Alex, for everything you contributed so far. You know, I'm so proud to be a part of this talk with Pain BC. I am Desmond Williams. I'm the son of Ike Williams and Patty Williams, née Patty Carey, and I'm coming to you from the stolen traditional lands of the Musqueam, Tsleil-Waututh, and Squamish people, and more specifically, I am closest to the settlement called Kemkemale, which in the Squamish traditional language, it means grove of maples. Today I'm here as a representative, a person with lived experience who does a lot of work with Pain BC. I am on the board of directors for the National Advisory Committee for Pain Canada, and I also sit on the board of the Pepper Project, which is a collaboration between Pain Canada, Western University, the Chronic Pain Society, and a number of other people. And I am really proud and honored to be able to contribute my voice and my experience to all of these wonderful projects. And it's something that at this point in my life is something I have the capacity for, but I can say that if you talked to me about 10 years ago in the process of dealing with my pain, I wouldn't have been able to articulate my thoughts and my feelings because I was being consumed by the pain that affects me still to this day. But I just didn't have the tools and strategies that I'm lucky enough to have acquired at this point. And so that's kind of why I'm here today, is to share a little bit about my story and some of the things that I do to help maintain and fortify my mental health when it comes in relation to my physical pain. So to start off, I will say that I'm somebody who through the years has not had a lot of success with cognitive-based help when it comes to my mental health in relation to my physical health. And when I was in my early 20s, because of my physical pain that I dealt with pretty much every moment of every day, I dealt with a lot of anger, And I was not able to engage in the present moment with people most of the time because I was so consumed with the internal dialogue of what was happening with my pain and how I felt about it. But I didn't have an outlet. I didn't have a way to express that. And I didn't have anybody who I could actually trust to talk about it. And so when I started to actually realize that I was being consumed by my anger, first off, I didn't know that the anger was in relation to the pain that I was experiencing. I thought that I was just an angry guy. And at the time, I happened to be in a job in a space that being an angry man wasn't actually that bad of a thing. It was kind of normalized. And I was not only allowed to be like that in that space, I was kind of like the baddest, meanest one. And so I almost got some regard for that. But I realized after a while of being in that environment that it definitely was not a supportive or positive place to be, allowing my anger to flow the way that it was. And so there was a time where I originally wanted to work on my anger, and I started to look at what we consider anger management courses. And every time that I looked at a description or a breakdown of what anger management was about, I got angry, which was not helpful for the process. And I am so blessed and so lucky to have people in my life that have just suggested things along the way that were very helpful for me. And one of the things that I did not realize in this journey early on was that a lot of this anger that I was thinking about was living in my body. And I was suggested a practice called trauma release exercises. That was a suggestion based on, I had reported that I had low back pain, and a friend said, hey, this is supposed to be really good for low back pain. So I decided to check it out. I tried it out. And after some time doing the practice, I realized that not only through the theory was I understanding the relationship between the physical pain that I was dealing with and the anger as well, I started to realize that in dealing with the physical component of it, the anger was starting to make a lot more sense. And so when it comes to the way that we relate to our bodies, many of us think of our brain and our body being separate entities, two things that we can work on separately, that work in separate spaces and aren't part of the same mechanism, one whole. And so in my revelations through the years, that was one of the major things that helped me to understand why I needed to start to address certain aspects of my physical structure in relation to my mental health. And with that, I'm not saying that like I need to solve my pain in order to be happy, because both of those things aren't really a possibility when you're dealing with a chronic condition that you know you're going to live with for the rest of your life. But there are things that we can do to rebuild our relationship with our body. Because what I found is that when I was dealing with pain, when I was dealing with the anger and the other emotions and thoughts that came along with being in pain and being angry all the time, I noticed that I actually had a very negative opinion about my body. And the way that I spoke about my body and I spoke to my body was very, very negative. And wouldn't you know it, my body also didn't have many positive things to say to my mind. In science and anatomy, we have what are called afferent and efferent neurons. These are our signal senders. We have as many in our brain sending signals down to our body as we do in our body sending signals to our brain. And I tell you about that because there is a feedback loop that we can sometimes get into where if we don't ever get any positive feedback from our body, how are we ever supposed to be able to break out of the negative feedback loops in our mind? And so finding strategies is a critical thing in this process. I believe in finding things that can offer positive feelings in our body. And so I have already talked about the practice of TRE. It's something that I have been doing for 9 years now. I do teach that on my own time. to people, friends, family, and anybody who is interested, because I have found that it is one of the easiest and most accessible practices that I have come across in allowing my body to offer me positive feedback in moments of distress, in moments of pain, in moments that I just can't get out of my brain. I allow my body to lead the process. And in allowing my body to offer me moments, even just moments of positive feedback, can give my brain the break and the space to be able to come to a new place when I'm having a really difficult time with my mental health. And so the other thing that I want to talk about when it comes to, stress and physical pain is that stress and trauma are actually on the same continuum. And the thing that will separate a stressful situation and turn it into a traumatic situation is when the components of helplessness and hopelessness are incorporated into this situation. And so those of us who are dealing with chronic pain, those of us who have diagnosis, or even mystery things that are happening that we don't know are going to end, or we know are never going to end, we have this for the rest of our lives. There is a component of helplessness and hopelessness that is inherent in that experience. And with that, it etches trauma into our system. And because of that, there are things that we need to be able to do to support ourselves through this process. And with that, there are simple somatic practices that can sometimes be very simple, accessible, and easy in the moment, and also very cost-effective and affordable, that can support you through these processes until we can find spaces to find more help. And so a quick suggestion of those types of things, it can be as easy as altering your breath and deepening the inhale and the exhale, or finding different styles of breath work or pranayama in the yoga practice. We can go into body-based practices such as somatic therapy or TRE. Even things like yoga or meditation can be helpful in finding the space and rebuilding our relationship with our body. And these are just some of the tools that we can use on our own. But I feel one of the things that was mentioned a couple of times today already is that there are things that we need outside of ourselves to be able to support ourselves as well. And so we are lucky to be in a Pain BC webinar right now. For those of you who don't know, Pain BC has been functioning for a number of years now, creating materials and things for people with chronic pain to engage with in order to support themselves. And a number of these things are also very helpful for our mental health. And so there are programs like the Live Plan B Plus material through the Pain BC website, the Power Over Pain portal that Jennifer told us about. And there are a number of things that are happening on the forefront of the pain world right now, such as a whole conference dedicated to chronic pain that is designed by people with chronic pain, called the Putting the Pieces Together Conference for people with pain by people with pain. Myself and Alex are some of the people that are contributing the material to that. And there are just so many things out there when we are able to find the space to look for it, that people have started to create to help us deal with these things. And I guess the conclusion to this is that it feels like when we're dealing with physical health, mental health problems that are so internal that sometimes it's just us that is dealing with it. Sometimes it feels like nobody understands exactly what we are dealing with. And that may be true, but there are materials out there to help us deal with these feelings, with these sensations, whether it be physical, whether it be mental, emotional, or spiritual pain that we're dealing with. And one of the most important things that we can do, aside from looking within to see what we can do for ourselves, is to actually reach out and to know that there are things there for us to grasp and to hold on to support us and maybe even pull us from the deep from time to time. So that is all I have to say for today. Coach Jim, thank you. And send it back to Alex for our Q&A.
Thanks so much, Desmond. I have to say, I feel very called out by the whole looking at anger management resources and getting angrier thing. So I think possibly I need to look into TRE. To that end, we do have a question from the audience, and they're wondering if you can talk a little bit more about what exactly TRE is.
All right, right into it. We're back with me right at the start. That's okay. I love to talk about TRE. It's one of my favorite things to talk about, actually. I had to restrain myself to stay within my time limit, so I didn't talk too much about it. So thank you for asking, whoever that is. Trauma release exercises, or TRE, is a very simple, gentle physical practice where we just do a couple of stretches where we are engaging the muscles in our fight or flight response system. And then what this practice actually does is it evokes tremors in our body, which is the mechanism in our body of our brainstem, our vagus nerve, and our psoas muscle, releasing energy and tension that is held in our body from past fight or flight experiences that we have not had the chance to complete. So all of the times that we may have wanted to punch someone in the face, but it was not socially acceptable to do so, that energy actually gets locked in our body, along with the memory, the stress of the experience, all the times we wanted to run out of a room because it was just uncomfortable, but we didn't do so, either because it was not safe or it wasn't socially acceptable. Again, a lot of this has to do with socialization. We don't get to complete these fight or flight responses. And so this is a practice that actually evokes this tremor mechanism that has been waiting for our entire lives to be evoked. Every single body shakes. Every mammal has this release mechanism in their body. But us as humans, we've actually been socialized out of this practice because in our modern Western colonial frame of reference, there is no positive frame of reference for shaking in our bodies. Neurological disorder, it's Parkinson's, it's voodoo. There's all of these different things in our colonial society that we have negative connotations for tremoring and shaking in our body. And so the fact that every single one of us has had a moment in our life where we were so angry, so upset, so scared that it felt like our body was shaking, but most of us have tried to stop that sensation instead of allowing our body to express it. We have so many of these moments living in our body. And so TRE is this incredibly simple process of just allowing our body to have its expression, to have its say, and to release this energy through the process of you lay on the floor and you let your body shake. And the hardest part about it is that we have been controlling our body. We have been stopping this tremor mechanism for our whole life. And so the work in the process is letting it happen. But I have not met anyone in my life in 9 years that I've been teaching this that did not shake. It's just that some of us don't want to yet. But it is a practice that is incredibly gentle, is incredibly soothing. The most common descriptive word that I get on a first experience is that it feels weird because it's like, I'm not making this happen, but it's happening. And it feels nice, but it feels strange. And so it is, it's a really simple, accessible practice. I teach it. It's something that can be accessed by people who cannot get on the floor, who maybe have to stay in bed. You can do it in a chair. You can do it on the ground. You can do it in bed. You could even find ways to do it standing up. It is an incredibly interesting and fairly new practice that is based in somatic experiencing and neuroscience. And like I said, I could talk all day about it, but that was like my short version. And if anybody does have questions or would like to know a little bit more, I do have a website, www.vibestre.ca, VIBESTRE.ca. And there's a lot more information out there about TRE the efficacy of it, but it is very new. It was first kind of created in 2001. And so you could say that a lot of the research that has been done either has not been published yet, has been shelved because it worked better than the thing that was actually paying for the research, or yeah, it's just not as out there yet. And you know, it's interesting to be one of the people that was doing this really, really early on, before we even had global certification and all of that. And yeah, I'm just gonna end it at that. But TRE is my favorite thing to do. It's so accessible, so easy. And once you learn it, you can do it on your own. So if it works out for you, it will cost you a couple dollars at the start and then never a dollar after that, which for me was one of the main selling points.
All right, I think we've got time for one more question, and I'm going to direct this at Dr. Stinson. It is maybe a little bit of a broad question for 3 minutes, but I'm wondering if you have any advice for clinicians, researchers who are sort of interested in engaging with co-design practices, and also for people with lived experience who might be interested in participating in co-design processes but aren't even sure where to find these kinds of projects.
Yeah, I'm happy to talk about that. So I think co-design is part of like a user-centered design approach. It's really focused, usually it's come from like engineer development. You're developing a specific project or a product. And in our case, it's like the website or an app. And you always need meaningful patient engagement in that and building on that trustful relationship. And so some simple principles that I use is that we really try to ensure diversity in the youth that we get. So not just picking the patients that are going off to med school or psychology or whatever, but really trying to get those more equity seeking groups. And that other key principles is that you need to take time to build trust with them, find out what they're interested in doing. And we never actually involve only one patient partner. We find it beneficial to have a group of young people together, because that experience of being together with that group, I think it was Dawn maybe that said, you don't know anyone else with the same condition. And so it's quite therapeutic to bring them together. And then the last principle is that usually I have one member of my staff that's dedicated to trying to keep them engaged throughout the whole process, and being flexible, because, you know, you got people with pain will have flares or come in and out of projects, and that's totally okay. But yeah, it's so important. We won't get it right unless we involve patients from the outset in what we're trying to develop for them.
Thank you so much. And I think we have time for one more very quick question, which I'm going to throw to Dawn, which is, we've shared the Power Over Pain portal on Desmond's website. I'm wondering, I know things are a little up in the air with the state of X, aka Twitter, but do you have somewhere you'd like to direct people if they're interested in Spoony Chat going forward?
They can still reach me on X. They can also reach out to me on LinkedIn if they want to find out upcoming topics and that kind of thing. And there will be a Substack shortly called Spoony Chat.
Amazing. Thank you so much. And I will throw it back to Ari now for a couple wrap-up slides.
Thank you so much, everyone. I don't have any slides. I'm just going to pop the link for our survey in the chat. So if you could please just take a couple moments to complete that. There we go. Before you head off today, that would be great. As I mentioned, a recording of this talk will be available probably later in September. But thank you so much, everyone, for joining today. Please, if you have any lingering questions afterwards, feel free to contact us at education@painbc.ca. Otherwise, thank you again to all of our presenters and to Alex for moderating this fantastic talk. I hope it gives you some food for thought.